Well, good morning, everyone. We are going to get started. And welcome to day 2 of ICFP, of what promises to be another day of a lot of very engaging and exciting presentations and conversations. So welcome also to all of those who are joining us virtually, and all of you I know are so committed to the advancing the cause of family planning. So I was excited to see that ICFP this year would focus on the nexus of universal health coverage and family planning. This is a subject that is very close to my heart. And it's critical, I think, in advancing and closing the gap for unmet need. This year's ICFP theme, it's a testament to the family planning community's efforts to demonstrate the interconnectedness of achieving UHC, so universal health coverage, and expanding access to family planning. And while world leaders have committed to achieving UHC by 2030, still today, more than half of the world's population does not have access or lacks adequate access to primary healthcare services. And this includes 218 million women who want contraception but do not have access to contraception. We also know of the really devastating impact that COVID-19 has had on health systems, including in many countries, a disruption in family planning services. And I hope to talk to our panelists about that today and how they have seen and experienced this. COVID has had. I mean, if we don't invest in addressing the issues right now, it will end up having a very damaging effect on our quest for universal health coverage. At the root of many of these problems is the fact that primary health care is more often than not the most under-resourced part of the health system. And 49% in low-income countries is the money that people have to pay out of pocket for primary health care services. And who uses primary healthcare services? Actually, when we look at the client base for primary healthcare services, it's women and children, because primary healthcare services tend to be located close to home, and women have transport issues, especially women living in low-income areas. And so it's women and children who suffer when primary healthcare systems are not up to meeting their needs. And so one thing that we feel is really essential to understand and advocate for is that a well-designed primary healthcare system should and can meet the needs of most of the health needs of people throughout their lives, including most of women's health needs, such as family planning, antenatal care and delivery, nutrition services, pediatric care, vaccinations for children, vaccinations for themselves, and more. And as I was talking yesterday in my intro speech, often we find that health systems and primary healthcare systems are not designed with women's needs in mind. Sometimes I have seen that pregnant women have to go up to the second floor to actually get their services. I'm from Pakistan, and one of the things, and so I'm a pediatrician by training, and one of my sort of big career focus has been working in communities and community health research to make innovations that are accessible to people living in low-income countries. One of the most frustrating things I would go through when I was doing this is how siloed health systems are in developing countries, and in many places this continues to be the issue, where antenatal care and MNCH services are separately housed, immunization is separate, population welfare, family planning is a separate service, and women are referred from one place to another without any thought given to do they have transport. I remember how often in immunization services, women would come and ask quietly whether we offered family planning, and we would say, no, you go elsewhere. And who knows whether they ever got to that elsewhere or not, and how many unintended pregnancies resulted as a result of this. So quality healthcare for women and children does not only mean access, as all of you know. It's also quality healthcare. And one of the things we talked about yesterday is how many women start a contraceptive method but then discontinue within the year. And one of the reasons that happens is their preference is not met. So they're given any contraception, not the contraceptive method that was their first choice. And so access to choice is a very important part of family planning services within UHC. It's been, so I mean, I've talked about challenges. There has been progress, and so we do acknowledge the progress. There are many countries that have taken big steps. For example, Uganda approved its first ever national social health insurance scheme, which included family planning, counseling, and services. Ghana, and one of our panelists here is from Ghana, introduced family planning into its national health insurance scheme. This is progress that has to be acknowledged, but we need to see much more. And today we have 5 panelists with us who have unique insights into how to advance UHC and scale access to family planning within primary healthcare systems. And they represent the 5 sectors that we think are critical to doing this, government sector, private sector, NGOs, donors, and civil society. I'm going to introduce people by the order that we see them here. So we have the esteemed Dr. S.K. Sigdar, Advisor for Family Planning and Maternal Health in the Government of India's Ministry of Health and Family Welfare. And Dr. Sigdar told me it's his 4th ICFP, correct? Yes. We have Mariba, who had the good pleasure of meeting earlier this year in Senegal. She is Director of the Ouagadougou Partnership Coordinating Unit. Then I have Aurelia Sowa Mensa, and Aurelia is an ICFP Youth Trailblazer Award winner, and she is from Ghana. And then I have Dr. Klaus Roon, who is Bayer's Senior Vice President of Market Access, Public Affairs, and Sustainability. And last but not least, I have Dr. Hasto Wardoya, who is Chairman of Indonesia's National Population and Family Planning Agency, BKKBN. Thank you so much for being here. So I'd like to begin by asking each one of you to describe in your own words how you have worked hard to advance universal health care coverage and access to family planning, especially focusing on those links between UHC, PHC, and family planning. And I'll start with you, Dr. Sigdar. And each one of you has about 5 minutes.
Thanks, Anita. And it's really a pleasure and privilege to be here amongst all the distinguished colleagues here on the dais, as well as the participants across the table. And as Anita mentioned, it happens to be my 4th ICFP and probably the last. And
I hope not.
and I'm really happy to be here amongst our own community. I'm representing the government of India, and probably on this panel, I'm representing a government of any country. Here, what I would like to emphasize that I've had the opportunity and the opportunity to work in all sectors of reproductive child health. So I've handled the maternal health division, the family planning division, the child health division, the immunization divisions, the adolescent health divisions. The whole spectrum is something which has been under my belt. And the one which has been really very, very invigorating and pulsating for me has been the family planning program, which I've been now spearheading for the last 16 years. And having said that, I believe that these are the programs which can make a huge dent in the health of the women and children of our country. I would confide that when I entered the family planning program, I was thinking only of population control. That was the only thing which was in my mind. But 6 months down the line, or by 1 year, I was a converted person, and I said, it's not about population. It's about health of the mother and children. And that is something what we have achieved over so many years of hard work. So while talking about the primary healthcare as well as the linkage with the UHCs that this panel is talking about, I feel family planning plays a significant role together with maternal health. So if we are really looking after these two programs together, the synergy between the maternal health and the family planning, it's really brought out by the fact that the number of unwanted births which this family planning can avert, the number of maternal deaths that family planning can avert, these are humongous numbers. So there is a good case for these programs to be seen together. And we in India have been able to get a dividend out of this concerted synergic strategy. What we have done is that come out with people-centric programs, with having our last mile coverage through our contraceptive supplies, as well as reaching the woman in the village, the couple in the village who may be far off in our huge country of 1.4 billion people. So this huge population throws up huge challenges, and this huge population, together with the challenges, give us the opportunities to work in a differential way, a differential planning. And it has really been a very satisfying experience when you see the smiles on the face of the women and the men in the far corners of our country when we go to visit them. They would say that the government has come up with this scheme, the government has come out with that scheme, which has been beneficial to them. For example, in our case of the maternal health, the institutional deliveries in our country have now gone up to 90% on an average, whereas half of our states in our country have already around 99%. There are a few which is around 87 or 88%. So with this particular sort of a huge gain that we had through very well thought out programs like the Janani Suraksha Yojana, which is a conditional cash transfer scheme, and the Janani Swasthya Shishu Kendra JSSK scheme, where we are providing benefits to every mother. So every mother who comes for a delivery in India gets everything free of cost, right from the transportation from the house to the hospitals, as well as for their drugs, their diagnostics, their blood, and for surgeries. Everything is paid for by the government. That lady is not supposed to be paying anything. And on top of that, we pay them extra money for any contingencies that they have. So that has really led us for us to have this huge sort of a numbers of institution deliveries. And this institution deliveries, when they are captive in your hospitals, we don't send them back without some sort of contraception. It is not contraception, it is not a coercion, it's sort of a choice we give to them, at least to get away from the unwanted pregnancy, which many of them are subjected to. I believe the synergy between these two programs are the ways and means on which other countries can also look into it, that to achieve indicators, whether it is for family planning or maternal health indicator, if you work together, you will be getting the best indicators and achieving the SDG goals where we want to say, leave no one behind. Thank you.
Thank you, Dr. Sikdar. And the high number of institutional deliveries actually makes postpartum family planning a very
That's right.
viable option in India. Yeah,
That's been a success story.
Yeah, great. Thank you so much. Marie,
Thank you, Anita.
How about you?
Sure. Already a pleasure for the Ouagadougou partnership to be here, and I hope as we are attending more ICFP, more and more of the attendees are familiar with the Ouagadougou partnership, but I'll take time just to explain who we are. So we're not a government. We probably won't have achieved as much on UHC, but we are a locally led movement by 9 ministries of health, where in countries where you traditionally had some of the worst indicators in terms of maternal death, in terms of low contraceptive prevalence rates, and a group of donors who have traditionally been also funding family planning. And so the idea was to reposition family planning in the first phase, and then in the second phase was to accelerate some of the progress. So we've made great strides in terms of the contraceptive prevalence rates. Between our 9 countries, we're ranging between 10-12% for some, and all the way to 30% for other countries. So the results are very different, and they also have very different baselines and different context as well. Within the Secretariat, our objective is not implementation, it's coordination. And so one of our focus, at least we have 5 focuses. So one of our first priorities is on youth, and I think we'll have an opportunity to talk more about that. But really working with youth as agents of change and as decision makers. And as Melinda was reminding in her opening statement yesterday, not just being around the table, but also having the means and the tools to actually be able to make sound decisions. Another objective of ours and a priority is on locally led research. There's a lot of research that's being done by international organizations that are really good about Francophone West African countries. We also have the issue with the language barrier. And so what we want is to promote local and regional research and evidence building to change and influence certain family planning programs in the region. Another area of focus is on family planning in humanitarian settings. We are in a region where between political instability, security threats around the borders, there is a lot of disruption in terms of service. So how do we improve family planning and making sure that it's part of the minimum service package for humanitarian settings? And also country lagging behind, as well as in social norms, is our fifth and biggest priority and focus. So in terms of UHC, because we are doing coordination and some countries are a little more advanced than others, what we're doing is making sure that we elevate the voice of champions, be it civil society, for the inclusion of family planning in UHC. And our countries are at different levels. I won't name the countries and where exactly they stand, but we want to make sure with the best practices and lessons learned that there are synergies and they can learn from each other in terms of family planning and including UHC in there. Thanks.
Wonderful. So I'll come back to the which countries, which countries have been. So you don't have to tell us which countries have not. Can you tell us which countries have included family planning in UHC?
Mm-hmm. So Ivory Coast, and I think Dr. Tano is probably in the room, but we have the 9 directors for maternal and child health. Burkina Faso also is pretty advanced in terms of including family planning in UHC.
Okay, so you have 2 trailblazers.
Yes,
okay.
Exactly.
Thank you. And I have another trailblazer over here sitting next to you, Aurelia. So Aurelia, tell us about how you think youth are contributing to this.
Okay, thank you. Thank you for having me. So I have been in the NGO space since 2014. And what we do is we like to go to the grassroots level, because when you are in an office or you are in the urban areas, you really do not see exactly what is going on. And so what we do is door-to-door advocacy. And so we advocate for mostly safe sex. And so that covers to prevention of STIs and HIV, spacing of your children, delaying childbirth, because most of these people in rural communities, they don't have any source of entertainment. And so there's this constant unprotected sex that they use to entertain themselves and end up getting pregnant, end up having unsafe abortions. People keep dying. And so what we do is we give you the information, we tell you where to get it, and if there isn't any youth-friendly service, we try as much as possible, come back home, speak to the NGOs, and if they can set up a youth-friendly service in the clinic there or the pharmacists there should be equipped to help these children, because the pharmacist there is mostly selling drugs for malaria, something for headache, but nothing for family planning. Or he or she doesn't even know what type of medications or contraceptions you can use for family planning. And so that's basically our job as NGOs and young advocates. And NGOs have created a space for young advocates like myself who are interested in family planning and universal health coverage. And so if you can walk into a pharmacy or a hospital to get malaria medication, then you should be able to get family planning services from the same hospital. And so we've tried as much as possible to advocate for that. And we've also made it easier for those who have mobile phones. You can just call MSI, you can call Planned Parenthood Association of Ghana, you can call Ghana Health Service, or you can reach Ghana Health Service on their YMK app, and they can help you. There's always a counselor on board who is willing to help you. They can give you directions. Do you want to come to the clinic? Do you need us to send something to you? What do you need? And so that's basically how it happens. And it makes it easier for a lot of young girls, because if I am shy to walk in to a clinic, because I'll probably meet my mother's friend there, and she will go home and say, I saw your daughter, she was getting post-pill. I mean, that child has a phone. A lot of young people have phones at home. You can just call MSI, and then they'll walk you through what you need to do. or if they need to meet you somewhere, they will. And so that's basically what we've been doing so far.
That's great. So, I mean, so what you're saying is that we should really think broadly about what are the needs of youth and how we can make it easier for them through a variety of ways, whatever works for them, to have access to family planning, including pharmacy, drug shops, which should all be thought of in the context of universal health coverage.
Yes, and also what we mostly do is we find out what the need is in that community.
yeah.
Maybe they don't need family planning. Maybe they need menstrual health management. And that also has a link to family planning because girls that cannot afford sanitary pads will be deceived by a man who can provide it for her, get her pregnant, and because he's not willing to take up responsibility, she will in turn try to get an abortion unsafely. She can die. And so if providing sanitary pads to young girls in a community will prevent them from getting pregnant or from committing unsafe abortion, and that is what we will do.
Yes, thank you. Yeah, and that's an important link that you're making there to menstrual health as well. Klaus, how about you? The Bayer perspective.
Yeah, thank you, Anita. And as we actually hit the 8 billion mark in terms of people living on this planet, we have to acknowledge that 50% of the world's population lack coverage for medical services and or products.
Right.
So, and as a representative of Bayer, I'm in charge of really making sure with my team that worldwide we have sufficient access to our products. No matter what the income level is in the respective geography that we're operating in. So our company's vision is health for all, hunger for none. And if you think about the sheer numbers of people that this embraces, it is really a true challenge for us. So the question is, what can we contribute? In terms of UHC, of course, we have to make sure that affordability does not become the major hurdle of products getting reimbursed. So as a company, like many of our industry peers, we have introduced tiered pricing across the globe to make products accessible also in low and middle income countries. So this has given room to expand coverage, but of course there's still work to do, especially if you think about specialty medicines. Today is also the day the Access to Medicines Index will be published, so it's going to happen later tonight, local time here. So watch out for the results. That's where you can see whether the industry is walking its talk and what the progress is in terms of product accessibility, capacity building, governance of access, and R&D efforts. I think it's an important index and an important measurement of all the health topics that are related to access. As the world's leader in women's healthcare, we, I think, have a special responsibility in the area of family planning. The last conference I was sitting on a panel was actually ICPD2019, so ICPD25 in Nairobi, where we actually shared our commitment to have 100 million women in low and middle income countries gaining access, incremental access to contraception, modern contraception by 2030, and we come to that a little later. And I have to say, it's an exciting journey for us because we're actually leaving the traditional role that we've been in, which is a sheer supplier. So we've increasingly become a partner in the ecosystem, in the family planning ecosystem, and I think that's mutually beneficial. And I have to say, on a more personal note, I think it's one of the most rewarding journeys I could ever think of in my professional career. So thank you very much, and I look forward to today's discussion.
Thank you so much. Thank you. So the index of the medicines for all index is an important measure, I think, for pharma companies that we should be also highlighting more in our work, perhaps to get other people to step up, other companies to also step up. Do I hear that?
Of course. So for us, it's an important tool to measure our progress on our access agenda. So, and I know that for many of our peers, it is the case, but there is still work to do.
Okay, wonderful. Thank you. And now to you, Dr. Hasto, Professor Hasto, if you can give us the perspective from your side, it would be wonderful. And I understand you have a presentation that you want to make.
Yeah.
Yes.
Okay. Thank you. Madam. Morning. I want to present about the Indonesian health coverage and into the family planning. The number of Indonesia have become a member of national health insurance is 86% of population. So we have 273 million population. Yeah. So I think the national health insurance program is committed of Indonesia to achieve of sustainable development goal and to decrease of maternal mortality, infant mortality, include the hunger and stunting. So the Indonesia have the three scheme to cover insurance of the family planning services. The first is family planning services financed through the National Health Insurance Program. Its name is BPJS, the National Insurance Program. And the second, family planning service financed by the government with the special program, maybe with the momentum, for example, social action, yeah, by special program arranged by BKKBN, yeah, my board. And the third, family planning services financed independent by private patient, yeah. So the National Health Insurance Program, the family planning services covered the counseling and pill, condom, and through capitation fee. But the injection, implant, intrauterine device, IUD, vasectomy, and family planning complication covered by fee for service, not capitation fee. Yeah. So another program, the family planning services are currently, but certain conditions, for example, family planning services include vasectomy, tubectomy performed in hospital must go through referral based on medical education. And then post-delivery family planning services in hospital, where the financing of family planning services involve package with the delivery, yeah, and no extra cost. Yeah. And then the second scheme program, the family planning services are not currently in the National Health Insurance Program, but contraceptive device and drug will be provided by government through BKKBN, my board. Yeah. And contraceptive service that implemented in community catering, even social services. In the addition of the National Health Insurance Program, currently for financing of family planning service are also provided through the government program. The financing of family planning services is guaranteed by the government program through the National Population of Family Planning Board, which are provision of contraceptive device and drug for all childbearing age couple. And BKKBN rule in ensuring availability of contraceptive device and drug health to facilitate, including midwife and private practice. So the provision of a budget for mobilizing family planning services for long-term contraception method and with the is financing for medical costs for the health worker, especially for family planning services that are not guaranteed or cannot covered by the National Health Insurance Program. This financing is through the special allocation fund from the central government to the local government, district and city. So, and provision of supporting facility for family planning services and healthcare facility into the government, local government until the practice of midwife, providing operational costs for family planning services for the cost of distributing contraceptive device and the drug. I think so clear about the coverage of government to services of the family planning for central government under the local and district and the village by midwife private practice. Thank you. Yeah.
Thank you very much. Thank you. And I'd love to come back to your midwife question later on in the panel. Okay, so Dr. Sikdar, I have another question for you. India has been has seen major progress in ensuring access to family planning, and you really covered that very well. In the next 5 years, what are the 2 to 3 ways in which you see bringing UHC and family planning closer together?
Thank you. So I can start by saying that all of you must be knowing that success is about the 3 P's, You have to have the purpose, you have to have the passion, and most important, you have to have the perseverance. And these 3 ingredients has together with built in with a vision, as well as you have to have sensitivities and sensibilities for your people, your providers, your policymakers. You have to be inclusive, reaching the people reaching the unreached, as well, if you look into it, that has to have a sort of a global connectedness also. All these ingredients actually lead to a success. And I must say, you mentioned that India has succeeded on many fronts in family planning. I must say it has not come cheaply, because there has been a lot of sweat and toil in the hinterland of the country. And also, we have been smart enough to come up with policies which were viable, which were practicable, which were replicable in the different and distant parts of our country. So what we did initially to get the success was that we are not sitting on the legacy of 70 years of our family planning program. In fact, in the last 10 years, ever since we made a commitment from the podium of the London Summit on Family Planning in FP2020, we have worked tirelessly. And here, what we said is that one size cannot fit all. We also cannot have just one policy for the whole government or one program for the whole country of 1.4 billion. Incidentally, our population, our country has around 650 districts. You'd be astounded to say that we actually came out with 650 district plans. We analyzed each and every district, we mapped them, and we came out with interventions, with district-specific interventions. And that was a hard work we did after the FP2020 commitment came into being. And not just that, we kept on backstopping them and monitored them at the field level. So the results were there for everybody to see that what we achieved in these last 8 to 9 years is astounding. We have achieved less than the replacement level of fertility. Right now it's only 2.2. We have added 24 million additional users, which is stupendous. Together with that, our teenage fertility has reduced by half. Our teenage marriages too has reduced by half. And our spacing services have gone up by 7%. And more important, that what we are seeing is that the contraceptive prevalence rate that you just talked about, it increased by as much as 8%. That's a huge leap forward. because the track 20, which governs the FP 2020, used to tell us that your progression rate will be 0.4% per annum. Actually, we achieved 1.12% per annum. That was 4 times the projections given by track 20. That's on the back of the extra work and hard work that we did for the country, and we are continuing to do. And again, as you mentioned, going into the future with the FP 2030 bandwagon now, we have our priorities clearly set up. We have already committed to FP 2030, and we are probably the only country in the world which has already come out with a vision document for FP 2030, which is on the website of the FP 2030, wherein we are putting a lot of effort on the civil society, also on the civil society front, also on the private sector front. And again, for the UHC thing, it has been inbuilt in our national program that to achieve the UHC, family planning is one of the vehicles through which we will be able to achieve the FP 2030 goals. So what we've learned is that it's not how hard you hit. It's actually when you get hit hard, how you bounce back and be resilient. That's what we have done. Success is one part of the story, but I believe maintaining this success is also going to be one of a project for which I think we will have another day to discuss. Thank you, madam.
Thank you, Dr. Siddharth. That's great. Marie, coming back to your experience with the Ouagadougou partnership and working with different countries and the different considerations that you are thinking about as you approach FP 2030 goals. Any insights into how the UHC and FP agenda can move forward, and what are the main things that you worry about?
Right. And I was particularly interested in hearing Dr. Sikdar, because we have a very ambitious goal that we set up in 2021, which is reaching 6.5 million additional users by 2030, which is very ambitious for our region because in the first phases, most of the countries, we did reach and surpass our objectives, but to actually reach those objectives, most of our countries had to double their contraceptive prevalence rates. And you had countries like Senegal who were able to reach at some point 4% increase per annum. But that hasn't happened in a very long time. And as our countries are plateauing, we are looking to UHC as a strategy to actually reach our objectives in terms of contraceptive prevalence rates, in terms of additional women users. So I was particularly interested in hearing the results that you had. And for us, our niche and our focus is on policy and inclusion of family planning in UHC, and we'll leave costing and access to other experts. And so our role was also to bring all of the stakeholders together. Having conferences like these with this focus and this theme for this year is also an excellent traction for the passion that you talked about, the perseverance, to then have those local conversations. And how do we turn those conversations about the need to include family planning in UHC into concrete action? And for us at the Ouagadougou Partnership as a movement is to bring all of those experts on access, on costing, on policy, on decision makers, and figuring out, we have similar context in the region, but we have very different countries also dealing with different governments. In terms of priority, I think we were having the conversation why some countries had not included family planning in their UHC program, and it's a question of budget. Sometimes it's a matter of priority. There are other, let's say, burden of diseases that they think are more important. So obviously there's more focus and more attention going to that. And so for us, it's making sure that family planning is at the forefront of those conversations and turning those into action plans that by a certain deadline would make us reach that full inclusion of family planning and a wide array of family planning services, quality family planning services in UHC. And so, for example, in one of our OP annual meeting, I think it was in Conakry in 2017, where the Minister of Health had come to the meeting and just had a very open conversation with the audience from the 9 countries about how to improve family planning services. At the time, their program, their UHC program and inclusion of family planning was pretty nascent. It had just started, and having those conversations, and even so for those countries, it was how to improve their UHC, and for others, it's just mere inclusion into the UHC scheme.
So one of the powers of the OP partnership is the ability to learn from each other. So are you hopeful that in this UHC, family planning being an essential part of UHC, countries can learn from each other and prioritize?
Right. And in terms of learning, so there's 2 things that we plan on doing and that we usually do pretty well. It's those exchange programs, as you've mentioned. And for now, we've had them among the 9 countries, but if there's success in other regions, we're more than happy to learn from. And so I think having conferences here with our stakeholders that are in the room, hearing about the importance when we go back home, it's easier for us as a movement to have those conversations. That's one. And so having those learning opportunities among the 9 countries. The second aspect in terms of evidence building that I was talking about in the opening remarks, because we're wanting to grow locally led evidence building, we had a workshop recently, and one of the topics that came out in terms of priorities was UHC. So what evidence do we need to build for policymakers within the Ministry of Health or within civil society to then be able to advocate for family planning inclusion into UHC? So we really want to have a focus in our new research agenda on UHC.
Okay, thank you. That's great. Aurelia, you talked about raising awareness and engagement with grassroots about, what are the possibilities for family planning or whatever health needs populations and especially the young women and girls have. How about advocacy to policymakers? And have you had much experience or seen good examples of where advocacy to policymakers for youth issues, including family planning provision as an essential service? What can you share?
Sure. So NGOs try as much as possible to invest time and resources to build capacities of young advocates like myself. And so after they are done, it is our duty as advocates to hold policymakers accountable for the commitments that they have made at the national level. And a typical and a good win for Ghana is the family planning services on our national health insurance scheme. So if you own a national health insurance scheme card or you have a membership on it, you can get free family planning service in any healthcare provider or healthcare center, which is a big win for Ghana. It took a very long time, but we are there. And hopefully it remains so. And so holding them accountable in the sense that I can walk into a healthcare center and find out if I can get free healthcare on family planning services. And if not, I can actually walk to the municipal chief executive or the assemblyman, because he is a policymaker, and find out why this particular hospital cannot give me family planning services, because you have made a commitment at the national level. And I can also walk in, and if a clinic doesn't have, I can find out why don't they have it. And as an advocate, it is frustrating to find out that I can't get contraception from a normal healthcare provider. And so I might have to ask them, do you need me to speak to Mary Stopes to deliver some contraceptions to you? Because obviously you don't have it. And you need it because the young girls need it. And so NGOs have done that. They have put that value in us. We can actually stand up for ourselves. And that's because we've had our capacity built over the years. Yes. Not everybody can go to an MCE, a municipal chief executive of the community, and speak to him. I personally know him. I make sure to know all the MCEs that we get, just for the sake of it. I might not need them for anything now, but in a case like family planning and on our national health insurance scheme, we cannot achieve universal health coverage without family planning. Then it is not universal. It's just...
Yeah. Right.
Exactly.
Yeah, I shouldn't use the word universal without family planning being part of it, right? I completely agree. Klaus, I understand that Bayer is holding a side event on new ideas about partnership and collaboration. Can you tell us a bit more about that? What are you thinking?
Yeah, happy to do so, Anita. So I think, I mean, the burden of the pandemic has been pretty high across the globe in various forms, and I don't want to go into detail here, but I think there was one learning that strong partnerships have helped us cope with a lot of critical situations that we've been in, and many of them were actually private-public partnerships that worked pretty well. And my hope is, and that's also what I see happening, is that these public-private partnerships prevail, and they actually are now a new, let's say, layer or a foundation to tackle some of the challenges also in the family planning area. So as a company, we have set up a few, let's say, guiding principles in terms of partnerships. So first of all, we want to have systematic approaches. So we want to have projects whose outcomes are measurable, which are data-driven. So that's one. The second one is they shall be scalable. So we're looking at partnerships where we can ideally scale up some solutions, because that usually is one of the biggest hurdles, right? When you think about the many activities and approaches that we see in different places, and including in family planning. Thirdly, they should be sustainable. So we are aiming for systems or offerings that are not donor dependent. So they should be able to survive after being initiated, brought en route, etc., etc. And lastly, and I think that's an important message for the private sector in particular, there should be freedom of choice. So none of the programs should depend on a single donor, a single provider, a single supplier. It shall be demand-driven. And I think that's also the learning from the private sector. If you really want to be a well-respected partner in the system, you have to make sure that you have this openness to include various solutions, products, expertise in those kinds of projects.
Wonderful. So it's a good advertisement for your side event. Yes, so I hope people come to that. I'm going to transition the conversation to COVID-19, and we had an opportunity to discuss some of the issues that the family planning world experienced during COVID, and it's very different by country. And so I thought we could spend maybe 5 minutes talking about 2 or 3 examples of how you saw COVID affect family planning. And so, Mary, I'd like to start with you. How have you seen COVID in the Ouagadougou countries impact MNCH and family planning and the UHC agenda? Have conversations on budgets that were happening, positively before become more difficult, or any other insights that you would like to share?
Right. Luckily for us, the severity of COVID in our region was not what it was expected. It was looking pretty doomed and gloomed in the beginning when we were hearing experts. There were deaths. So what we did notice, and some of the information we were getting, obviously, were closures of health centers in the beginning, service providers not reporting to work, obviously, because they didn't have the protection equipment to actually be able to deliver services. But very quickly, we went into lockdown most of the countries went into lockdown for probably 3 or 4 months at a time, and then it was over, and then we went back to business as usual. So our fear, obviously, was that there was going to be some impact in terms of budgets, of international donors, but also domestic funding for family planning. And so I think when the government realized that the impact was not going to be as severe as they thought, the levels of funding remained the same. Same thing happened also with the donors. I think there were a lot of conversations and advocacy from civil society and from implementing partners to keep the same levels, if not even to increase. And one thing we really appreciated in the region was the flexibility from certain donors to provide protection equipment for the service providers, because that was one of the biggest barriers. So the funding levels we actually, even in some countries, there was more impact from security threats and political instability than actually COVID on health centers being open and being able to deliver services. So that's mostly and we've been back to business as usual for almost a year and a half. We're we're having this running joke because, you know, at ICFP, a lot of people had this is their first international conference since COVID. West Africa, we've been flying and going to conferences and regional meetings for the past year and a half. So it was much better than we had anticipated. But I think there are some good practices and some lessons learned that we saw in terms of mechanisms and being able to have emergency meetings and conversations among stakeholders about how to keep the levels of funding. And one other thing that we did within the Ouagadougou partnership was coordination between the 9 directors of maternal and child health, and they were able to learn lessons from each other. Certain countries had already, because Guinea, for example, had dealt with Ebola previously, they were able to share some of the lessons learned from that pandemic with other countries who hadn't dealt with that at all. And there were also lots of lessons learned, for example, from Mali, because they had this strategy of using community health workers when they were doing door-to-door and outreach for COVID prevention, of also including family planning services and counseling and referrals. And so other countries were able to hear that experience from Mali and also be able to replicate. Togo, for example, was very interested in that and replicating that at their level.
Wonderful. And I heard this from you also, Dr. Sikdar, the role of community health workers in maintaining family planning services was very powerful in India. Yes, yeah.
Yeah, I'll just like to add on to what Mari said is, yes, we were also one of the, we were pretty hard hit to start with in COVID, and we were not as lucky as Africa was. But then we were very nimble-footed. We were very nimble-footed. We acted very fast, and within a month, all the machineries were in place. So the lockdown was there, all right. But as I told you that it's the community health workers who saved the day for us, because they were also invested with this particular, or rather given the responsibility of going from house to house to look for people having COVID or not, to get them to the facilities for testing and all these things. But we utilized, because we had a very good scheme already running in the country for delivery of contraceptives by the community health workers. So we really energized that particular initiative, and it really did wonders for us. Initially, we thought that our numbers would not be that high, our institution deliveries would go for a hit, but later on, as we see from the national data as well as the survey data, which really bore us out, was that the institution delivery percentage did not go as down as projected. Actually, it went up. 90%, as I said, was the National Family Health Survey. The DHS survey told us in 2021, it went up, the deliveries went up. And we took advantage of this institutional deliveries, which I just mentioned, wherein we put in place the postpartum family planning in a very strong way. So the woman who was delivering in a particular facility, in the labor room itself, we were inserting the postpartum IUCDs, which has been a runaway success during the pandemic. And those who were not really fit for the IUCDs, they took advantage of the Centromel, the indigenous pill that we have developed in our country, which is a non-hormonal non-steroidal pill. The Centromel usage actually went up by 4 to 5 times in every state of India. That was a revelation, and we learned from the COVID that there is scope for home care, there is scope for self-care, and that is something which has held us in good state. So COVID is a particular phase of our life which has taught us how things can be done differently, and how even after doing it differently, it can remain as a system going forward. So that has been some positive things which has come out of COVID, which we have now internalized in our program. Thank you.
So not a topic of this panel, but this is a really important point that you're making that I hope that we get to talk about more during the conference, which is that what were the positive lessons for family planning learned during COVID that we don't want to lose, especially on this high impact practice uptake in which community health workers, postpartum family planning are such crucial elements. Now, I know Indonesia was also very hard hit by COVID, Dr. Hasto, and do you want to share your experience on how you prevented or what happened during COVID for family planning in Indonesia?
Yeah, thank you. Indonesia is depend on services by midwife, I think, yes, yeah. Because about the 70% services family planning by midwife. So the government supportful with the practice of midwife. The government facilitate provision of the regulation guideline, for example, and for midwife, and then the government support by financing by the transfer fund from the central to the local government until the midwife practices, private and government practices. All of the practices of midwife can cover by the fund, local government, and transfer fund from the central government. And then it is very important to continuing training for the midwife. So BKKB in collaboration with the university and the academic of midwife make the pre-service training, especially about the IUD implant, removing of implant and IUD. It is very important pre-service training in the midwife. So I think it is very important pre-service training. Yeah, thank you.
So, so in Indonesia, midwives are trained in family planning methods, including IUD, implant insertion, and it's a regular part of what Indonesia does.
Yes, yeah. Inserting of IUD implant services included in the curriculum of the academic midwife.
Fantastic.
Yeah.
Klaus, I want to come to you, and we were, I mean, from a pharmaceutical company perspective, how did COVID impact contraceptive supplies?
I would say one thing first, and let's call it out. I think women have been hit most hard by the pandemic, so we shouldn't forget.
Yes.
I think 75% of healthcare workers are actually female. It's different in C-suites in the healthcare system.
Yes.
75% of women have been the frontline workers, healthcare workers during the pandemic. So, and many women actually, also during lockdowns and financial hardships, had to help their families gain their household income. So many of them have not been able to use family planning services that are being offered in their communities. So we've heard that in many places where we're active with our partners. So we had to, for example, adapt opening hours for women to be capable and able to actually visit those centers. And in many places, COVID treatments, other treatments, emergency treatments have been prioritized over sexual and reproductive health services. So let's not forget. So the question is, are we well equipped for this to be different next time around? I don't know. Yeah. So I would like to call this out. From a supplier perspective, of course, if you think about doing business in a globalized world, this has been a nightmare. Yeah. At least we can pride ourselves in saying we didn't have any stock outs, but it's been a huge stretch for the organization. The risk I'm seeing is that there is this tendency to friendshoring, home shoring, and every dollar invested into re-verticalization of supply chains is not available to invest into innovation and more outreach. So let's not forget. And the biggest issue we've been facing during the pandemic actually has been borders being shut down for trade. So that's also, I think, a gentle reminder that next time around, we hopefully see a free flow of goods, and that items which are supposed to help those most in need during a pandemic are not stopped at the borders. So I think that's something we have to keep in mind. Overall, still, if I look into our numbers, we still have been able to increase the number of women reached during the pandemic by 1 million users. But again, we shouldn't forget the number of unsafe abortions, unintended pregnancies, gender violence that has occurred during the pandemic. And I think it's still appropriate for us to talk about the lessons learned, how to make it better next time.
Yeah. No, and the logistics point that you make is also is really critical in planning for the future. How do you keep borders open for goods and services? Yeah. I'm going to switch to health systems, and I think I'll only get, because we are running, we have about 20 minutes left, so we will run out of time. And so Maybe I'll just ask two questions. One to you, Dr. Sigdar, which is, can you tell us a little bit more about the Ayushman Bharat Yojana and how that helps family planning? I know how it helps MNCH, but how does it help family planning?
So this Ayushman Bharat, Ayushman in Sanskrit, our old language, is that healthful life, blissful life, whatever you may call it that way. A wellness component is built in. So this Ayushman Bharat, Bharat is the name for India. So this Ayushman Bharat scheme was launched on 23rd of September 2018, almost 1.5 to 2 years before the pandemic actually started hitting us. And this was a very ambitious program which was inaugurated by our Honorable Prime Minister, wherein there are actually two vertical pillars to it. One is the creation of health and wellness centers across the country, and second is the insurance part that we are talking about. In the health and wellness center is something what we have done, a unique sort of a concept. 200,000 health and wellness centers were supposed to be set up, out of which 125,000 already are in place. And in the next 6 months, the whole 200,000 would be done. And these 200,000 are actually manned by community health officers, which are not medical MBBS doctors, but they are basically nurses, postgraduate nurses, in fact, BSc and MSc nurses, who are trained for about 6 long months on public health aspects, which includes wellness, which includes yoga, which includes communicable diseases, non-communicable diseases, and the reproductive and child health component, where we are dealing with mother and children. So comprehensively, what we are saying is these particular health and wellness officers who will be posted in this health and wellness centers will be catering to a population of pretty much around 5,000 to 10,000 population, around 5 or 6 villages. Basically, this is going to cover most of our country. That has been a success story, and it is doing well. Second part, probably on which you are alluding to, and probably of more interest to the audience here, is the insurance scheme, which we are calling Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. So again, it's a Hindi word. In simple English, it is the insurance scheme, where we are able to cover 500 million people, which means almost a little less than half of our population. We have around 1.35 billion. 500 million people are within the safety net of the government of India, and they are provided a coverage of $7,000 per year per family, which is a stupendous amount considering our country. And this is more of an ATM card, or rather debit card. The families can use this debit card every year, and whoever falls sick, this is basically for tertiary and secondary level of care in hospitals. There are about 1,360 odd packages for medical, surgical, gynecological, and family planning services, which is included in these particular packages. Since we got a little bit of setback because of the pandemic, we have been able to issue around 200 million cards already. Another 100 million is going to be done in the next 1 to 1.5 months. We believe that at the end of this financial year, which will be ending on March next year, we'll be able to have all 500 million cards in place. And that is something which is really changing the scenario. The aim and objective of this particular insurance card was to achieve the goals of the universal health care and the SDG goals, where we are saying that leaving no one behind. The important part of this 500 million coverage is that we gave our own states the flexibility to increase more people if they want. The states added in another 150 million. So in essence, it is covering 650 million population of our population, which is just half of our population is already taken care of. And this, we believe, going forward is the way that India is reaching its vulnerable population, because this 650 millions also covers around 108 million vulnerable and rural poor who are far from the safety net. We have also brought them under the safety net. So we probably think that going forward, the aim of UHC would be achieved and the SDG goals would be achieved over this particular insurance scheme. And I'm very proud to say that this particular scheme, if you are talking in terms of the numbers, it is bigger than the US, the Canada, as well as the Mexico put together. So the number is humongous, but we have got these things in place. Everything is through controlled through software, to monitored through software. So there is no leakage of funds or slippage of funds here. Thank you.
Okay, great. Thank you. And do the health and wellness centers also cover contraception? I mean,
Yeah. So
okay.
that's what I'm saying.
Right.
Initially, it was thought about that it's for communicable diseases and non-communicable diseases,
Yeah.
but the actual focus is on the RCH activities, reproductive and child health, where the maternal health, the family planning part, immunization was already covered. We are very strong immunization-wise in our country. The vaccination rates are very high. But this area of mothers, the institution deliveries that we are doing, and the provision of IUCDs, as well as your injectable contraceptives and condoms. In fact, we have come out with the concept of condom boxes. Or rather, because of the pandemic, we have innovated and we are calling it self-care kits. We are not even saying condom boxes. So every hospital, every subcenter, every PHCs are having self-care kits, which comprise of condoms, which comprise of emergency contraceptive pills, which comprise of pregnancy testing kits. These are all funded by the government because it's in India, we are the manufacturers ourselves. That being the case, it helps us. So a client who comes to access these services is not asked their name or whatever it is and the purpose. They simply take it from those self-care kits that we have put up, and we get the data, or rather we validate it by multiplying the numbers and getting the contraceptive, or rather CYP factor we get by multiplying the numbers.
Wonderful. Okay, great. Thank you. Klaus, I wanted to come back to this goal that Bayer has of getting into now delivery, access to population, and you have a goal of reaching 100 million women. So this is now Bayer getting into health systems change. So how did that come about, and how are you thinking about the sustainability angle here?
Yeah, thank you for the question. I referred to ICPD25 when we actually made the commitment as a company to reach 100 million women by 2030 in line with the UN SDGs. So I can tell you it's a huge stretch for the organization. It's nearly half of the gap that we have worldwide. And there is a couple of things that we have moved forward as a company. So on the first and foremost, of course, we need to make sure we have sufficient supply to reach these numbers. And we've actually built a brand new factory in Costa Rica just to serve this purpose. It's not a for-profit exercise that we're doing here. So it's been a big investment, nearly 200 million in a new site, 200 million euros. Secondly, we've scaled up partnerships. So, and the one I actually would like to mention here is also the one with UNFPA. On the one hand, in terms of supranational institutions, and of course, we have partnered also in initiatives like the Challenge Initiative, where we are amongst the donors. So the partnership component has really increased. And thirdly, we haven't touched upon this too deeply, but we are also engaged in humanitarian settings. So we're working with the International Red Cross on provision of services to women in situation of crisis, civil wars, etc., etc. And there, in particular, we offer logistics support. And logistics is probably also one of the biggest concerns today, because we see that air freight has got very expensive. And there is also a backlog in terms of cargo shipping, so by ship. So that's actually something which keeps us awake these days. Can we actually get the goods from the factory to the users? That's a very elaborated exercise these days. So, but we're on track. Actually, we've also been able to connect our milestones on the 100 million pathway to the remuneration of all our employees, all of our leaders.
Yeah.
So our board of management will not get the full LTI, long-term incentive payout, if we don't hit the interim goals. So we're pretty eager as a company, as you can imagine, to really achieve it. And it just stems out of the fact that the women's healthcare, as leader in women's healthcare, we felt this is the area where we can have the biggest impact as a company. And with the large footprint we have globally, We are well connected also in many countries with NGOs, with governments. We have initiatives in India, in Indonesia, and many other places around the globe.
And is this program run out of Bayer or the Bayer Foundation?
That is run out of Bayer,
Bayer.
so really out of the Bayer business. So it's not carved out and put into a foundation.
Okay.
It is part of our business,
great.
our business objectives.
That's great to see. I'm going to switch to youth now, Aurelia, and coming back to you. Tell us more about, you were beginning to get into this broader SHRH services, of which obviously family planning is a part. How do we activate more youth organizations and youth-led organizations into advocating for SHRH services?
I think we should find out what young people are interested in under SRHR. You know, SRHR is a very big umbrella. Not everybody is comfortable or will be comfortable talking about family planning. And so if one person is not comfortable, look for who is, and then build the person's capacity. I, for instance, am comfortable talking about everything under family planning. I got my family planning talk from my mom. A little over 16 years, she told me, if you want to space your children, you do it, and then if you feel like you don't want to have any more children, get a tubal ligation, because I got one. So my first family planning method that I had was tubal ligation. That was from my mom. And so I have been comfortable because right from the beginning, my mom has just been mentioning this, and so I have been comfortable. And so you need to find who is comfortable with what. If you are comfortable with menstrual hygiene management, we need to build your capacity in that sense and give young people a reason to want to work in these spaces. Some people may not see the need. Oh, okay, so if I volunteer with Maristops, and then what next? What people don't know is family planning and universal health coverage advocacy is an investment. Investing your time, your resources, your knowledge, and you might not see the returns now, but you will reap a lifetime of returns. And in future, you will see a young girl who went back to school because of your advocacy after she had a baby. I'm trying to convince one lady in my neighborhood to go back to school. When she wrote her final exam, she came back with two babies, twins. And she has no motivation to go back to school. But I told her, imagine these children grow up and their mom doesn't like to go back to school. It will demotivate them because we learn a lot from our parents. And so we should give them a reason to want to enter into this space and to want to advocate for family planning and universal health coverage. Also, we can use their own children as an example. If you are not interested, what are you going to tell your daughter? Because I may not be there as an advocate to help you with your daughter. Right now, I am mentoring a lot of girls because their mothers are not equipped with the information, and they have to hide from their mothers to get the information from us. And so if we train a lot of young people now, we will have a lot of adults who are going to pass down the information to their young people and other young people in rural communities who are not privileged enough to get the information that we have. And so it's just an investment that people should be willing to do. And we have to convince them that this is an investment. You are not wasting your time.
Great. Marie, do you want to add anything? How does OP think about addressing the issues that adolescents and young people face? I mean, the kinds of examples that we just heard from Aurelia.
And it's funny, a lot of the issues you were raising are exactly what we're hearing in our region as well. And I think we've been privy to a new generation. I don't even like to call them next generation. They've made it clear that it's the present,
the present
not
generation
the future.
And the future.
They've mentioned that yesterday in the opening ceremony. We get that.
Yeah.
So we've been incorporating more and more. We have a youth strategy. I mean, it's to the point where I feel like they're taking over our movement, and I feel like a youth association half the time. But it's a good thing because it allows us to innovate, to think differently, and oh boy, they've been steering us in the right direction so many times. And so there's two very focused elements that we're working on. There's an OP youth think tank that they've put together, and it's a reflection tank that they have where they're able to pair up with a more senior organization that's able to accompany them as they're setting their goals, understanding what some of the topics they're interested in, what types of research they would like the OP to conduct, and having a direct relationship with donors as well. So that's the think tank that they've put in place since 2016. But internally, we also have a very ambitious youth strategy. And when we were doing consultations to figure out what did youth want, so we started going into these grand schemes of what they needed in terms of access. And they did tell us, and that was great. But I think the number one item that came back for them was employability. And what they thought that the coordination unit could do was actually help them, because we have a lot of them that are coming from conference to conference, getting, educated, getting knowledge, but then because they have to get into the workforce, they have to go into a completely different field because we haven't created the space for them to find employment. So it's been a big focus of us and so of ours. And we have a program, for example, within the OPCU, where we do hire Ren, for example, who did an excellent job yesterday at the opening ceremony, is one of our youth leads. She's one of 3. And the previous cohort, when they ended the program, were all able to get employment. And that's really our message to other partners. We do work with youth. We make them come to conferences. They have messages. They're advocates. This is really good, doing sensibilization and advocacy. But I think there's so much more they can do in the realm, whether it's, capacity building, technical skills, social behavior change on social norms. I think the most important cohort of stakeholders that we have to actually address these social norms are actually youth. And that's really what we aim to work with them on, and their employability. And it's really one of the messages that we've been conveying to implementing partners. Put your money where your mouth is. It's very easy to take them from conference to conference, make them hold messages, but it's really a matter of giving them the tools and the means to actually even make decisions. And as I said, if you have them around the table, but they're not comfortable, being able to speak with their counterparts, if they don't have the technical skills to actually engage with decision makers, and that can be very intimidating. Yes. That's what they need, and those are the tools and the means that we're trying to bring to them. And so hopefully that makes for a stronger movement for the Ouagadougou partnership that's more innovative and that's younger in spirit and age, and bringing more freshness into our movement.
Yeah, it's a really key point. And part of this is also how little money, actually ODA money, flows into women-led movements and women-led organizations. It's actually only 1% of global aid money is what we call gender transformative and really addressing the needs of women and girls. So it's a big gap, and that results in the kind of thing that you're talking about, where yes, we train people to be advocates, but they cannot be, they don't have employment opportunities. Yeah, so I hear that. I think we only have a couple of minutes now, so I'm just going to do 2 more, coming back to the private sector, because I'm very interested in India. You call yourself the pharmacy to the world, and so how do you see private sector in India playing a role in the UHC and family planning as part of UHC movement?
Very much so, because at the heart of our programs, when we had the National Health Policy 2017, private sector was considered to be one of the big pillars, because all said and done, not in just the reproductive health arena, but in the otherwise overall healthcare arena, private sector caters to about 70% of our healthcare. But the fact is, this 70% is not prevalent uniformly across the country, more at the top level, say at the city level, at the district headquarters levels, but not below where we really need it. And especially the RCH services, the reproductive health child health services, this is something where the return on investment by the private sector is not as much. The private sector goes where there is profit. So we want to see it in a way, so we actually devised the scheme of Ayushman Bharat wherein we have pooled in these private sector providers and providing them money for provision of services in the far-flung areas of the country. And this is something we think is going to give us, together with that, especially in the family planning sector, family planning arena, what we have done a little bit of risk pooling so that the private sector also is there. The accredited private practice are taken care of in case of any indemnification that it's needed. The government is going to provide for them. And as I mentioned, all our products, although it is the pharmacy of the world, but then they are all private sector at the end of the day. So we get our commodities from the private sector, even the government. We have a government company, which is a public sector company, Hindustan Latex Limited, which provides around 30 to 40% of the commodities. But the rest of the commodities is taken from the private sector in our own country. So we are self-sufficient from that point of view because we don't have to import any commodity. So, and in terms of the provision of this particular family planning commodities to the last mile, it's the total government of India's own budget. We don't depend on any donor money, not even a single pence for any of our product. So that being the case, we are on a very strong wicket. And as I said before, during the COVID, what helped was that every single facility before COVID was stocked with the commodities as per norm. It was not that we pushed in there. It was already there. So during that particular COVID phase, those stocks really came in handy. So from that point of view, I think private sector is a very important vehicle for us to achieve the SDG goals as part of the urban universal healthcare supply chain as well. Thank you.
Okay, thank you. And Klaus, I'll give you the last word in 1 minute. So Bayer clearly is taking a lead in making family planning products accessible to women around the world. If you had a call to action for other pharma and how they could help, what would you say?
Well, I think the biggest question is where can you have impact at scale? And that varies by company, it varies by portfolio, geographical footprint, etc. So I think have a clear view on where you can make a contribution also in terms of UHC and do it, and be aware that health is not just accessible for a select few in industry nations where you may want to do the biggest profit. There is more people living on this planet. It's 8 billion. So I think that's the call to action.
Okay, thank you so much. So I want to thank all of you for your really thoughtful, insightful comments and your life's work in advancing the cause of family planning. And I want to thank our audience for being part of this panel early in the morning. And so with that, I will close this session. We are out of time, and wonderful to have all of you. Just the last thing that I want to say is we know that achieving universal health coverage and strengthening health systems takes the commitment, innovation, investment and advocacy of each of the groups that was represented on this panel and all of you in this room. And so I am just very grateful for your continued commitment to this cause. Thank you so much.